Hello and welcome to Serum Rhubarb. Today's session is on taking in neurological history. The assumption within this talk is that you already know how to take a structured history, and the idea is more to give you some ideas about how you can expand your usual practice, things to think about that are sometimes missed over the course of a history, and what we can do to frame common neurological causes to fit around the potential things we might encounter in the PACES stations. So we start as ever with the presenting complaint or the history of presenting complaint, which I've combined for these purposes. And first of all, we can talk about some general things to think about. One of the most important questions for any neurological history is the speed of onset of the symptom, differentiating your hyperacute, such as a stroke, your acute, such as the progressive weakness seen in a Guillain-Barré syndrome, or the chronic change, for example in a metabolic cause, will help you to easily decrease the list of differentials quite early in the history. Very obviously, which part of the body do they affect? Are they localized or more widespread? When did they start and how long do they last for? Have they had any history of trauma? And again, that's not something that always crops up to mind from medical questioning. Are the symptoms static or are they deteriorating? If they're deteriorating, are they doing so in a relapsing remitting format or in a stepwise fashion? Or is it just relentless and progressive? If there are remissions, does the patient return completely to normal between episodes? Or again, have they noticed some accumulation of neurological damage? Do they have any triggers for the symptoms? For example, exercise, poor sleep, their posture, or external stimuli such as light or smell? Of course, a good thorough history of any associated symptoms is extremely important. So then we look at common complaints that may occur, and this is more about focusing on some specific issues that you may encounter and how to approach that from a history-taking point of view. One of the most common presentations you may encounter would be a headache. And this is something that you'll have learned an approach to at medical school, looking for intracranial pressure elevation features, meningism, or other red flags are probably already quite thoroughly drilled into you. You'll probably approach this in the classical fashion with the mnemonic Socrates, the site, onset, character, timing, radiation, etc. And that's all very appropriate to build around. But just to add some extra information, it's important to think about other aspects and not be too rigid. For example, the early morning headaches, which we're all taught may indicate raised intracranial pressure worsened by the recumbent position of the patient overnight, could be something entirely non-neurological. They could have morning headaches from hypercapnia if they have obesity hyperventilation syndrome. Evening headaches, of course, are more suggestive of tension headache. The associated features are very important, and aura or other visual disturbance, nausea and vomiting, vertigo, photophobia, phonophobia, weakness, sensory change, pain and jaw claudication or hair brushing, fever and weight loss are all incredibly important to add in. A question that's often missed out is what point the patient is in their menstrual cycle if they happen to be someone who has a womb. And that's a common migraine trigger. Always useful, and again something you'll most likely do clinically, is to ask whether this has ever happened before, and if it does, is it any different from previously, and how so? What's the usual duration of their symptoms? And again, going back to those general points, has the headache come on hyperacutely, acutely, or chronically? Are they using large quantities of simple analgesia? If it's more than 16 days in a month, consider a medication overuse headache as part of the contribution. What do they do when they get the headache? Lying down in the dark would suggest a migraine, while being unable to stay still due to the pain would be more suggestive of a cluster headache. Another common presentation might be the patient reporting numbness or paresthesia or unusual sensations. One of the most common things to encounter within the MRCP exams is a history of MS, and this would be when you're thinking of isolated sensory change. So you could ask about relapsing, remitting symptoms. Do they have an Uthof's phenomenon? That is, the worsening of symptoms when exposed to heat, and we're all taught about the patient getting in a hot bath and feeling much worse when they come out again. Or Lhermitte's phenomenon, with reproducibility on neck flexion is observed. Be aware that this is not a symptom that is specific to MS. For example, if the patient has severe spondylosis in the cervical spine, they may cause impingement leaning forwards, which may also result in similar symptoms. You have to check to see if these may be occurring on a spinal level. In the associated symptoms, we would think particularly about weakness, visual changes, such as a quadrantanopia, a hemianopia, acuity change, change in the colour vision for an optic neuritis, or speech changes. The drug and the past medical history will be highly relevant to these symptoms, particularly in the event of a sensory neuropathy, and we'll get into those a little bit more once we hit that section. Is the neuropathy, if present, symmetrical, unilateral, bilateral, or isolated? Where exactly is it located? Does it correspond to a dermatomal distribution? Has there been a history of trauma to the affected body part? Could they have a Brown-Séquard syndrome if they had a spinal cord hemisection? If they've had an amputated limb, could they have a phantom limb syndrome? Or if they've had a mild insult and severe subsequent symptoms, particularly with evidence of sympathetic activation, could they have a CRPS? Is the neuropathy painful? Because the combination of painful neuropathy and psychiatric symptoms may alert you to a patient with variant CJD. If you have that under your suspicions, asking them about high-risk behaviour, such as eating bushmeat, transfusions prior to 1980, eating beef in an affected country prior to an outbreak would all be important things to ask. We also would like to think about foreign travel and sexual history in the differential of these, but again, these will be addressed more within the social history. Another common vignette you might encounter would be a patient reporting weakness, unsteadiness, stiffness, or clumsiness. It's important to characterise which actions in particular are impaired. Are they fine motor skills, gross motor skills, gait? Is the weakness worse at the end of the day, such as in myasthenia gravis, or could it be improved with repeated movement, as in a Lambert-Eaton syndrome? If the patient is stiff, does it improve with prolonged movement? And it may well be a rheumatological problem rather than a neurological one. Or with rest, do they just have osteoarthritis? If the patient is Parkinsonian, have they got any other features which could suggest something that's not Parkinson's disease? For example, autonomic dysfunction, suggestive of multiple system atrophy, or a vertical gaze palsy, typically encountering difficulty going down the stairs, which could indicate a progressive supranuclear palsy. Is there any evidence of dementia? In which case you could consider dementia with Lewy body syndrome. If intermittent, are the symptoms triggered by anything, such as carbohydrate loads or exercise in periodic paralysis? A third common change you might see in the clinical vignettes would be a patient reporting visual disturbance. As you are of course aware, it's important to characterise what exactly the nature of this disturbance is. Do they have blurring? Do they have acuity change? And that's particularly relevant if they've had a recent unremarkable optometrist review. Do they have double vision? Are they bumping into objects, suggestive of hemi-neglect? Is there a conjunctivitis? Have they had any change in their colour vision? Floaters, headaches, as discussed above, speech changes, weakness or paresthesia. Another presentation may be a patient with psychological changes. Now this would be a station that would be used to potentially throw candidates off. For example, a patient presenting with agitation, tearfulness, depression, elation, sleep disturbance. Now in the event of combined epileptic and psychiatric symptoms, we might think about a limbic encephalitis. If there's a painful neuropathy, variant CJD, or if there's concurrent dementia, a sporadic CJD, or potentially, if the patient's reporting a personality change and symptoms of frontotemporal dementia, we may think of primary frontotemporal dementia, or we think about motor neuron disease patients, as many of these unfortunately also suffer a concurrent frontotemporal dementia as well. Finally, I would think about whether or not the symptoms could be functional, but I would be extremely cautious with this. The fundamental point of the examinations are to make sure that you are a safe doctor, and a really key problem that's encountered is doctors wrongly assuming that neurological disease is functional. It's important to be aware that this is a common presentation, but also to make everybody aware that you are aware that the requirement is to exclude biological causes before you assume that something may be functional. Moving on to the past medical history, there are a wide variety of conditions that may cause or mimic neurological disease, or both. So, for the purposes of this section, because there is a rather overawing list of diseases that may contribute, I think it's helpful to go back to the medical school format and to group this into mnemonic format. So we've used the vitamin C mnemonic here, and there can be a variety of vascular causes. Atrial fibrillation leading to TIA or stroke, or indeed TIA or stroke from any other cause. Arteriovenous malformations, aneurysms, ruptured or unruptured. Diseases predisposing to dissection, such as Marfan's syndrome. Or any other risk factors for cardiovascular disease. There are a large number of infective causes. It's important to be aware if the patient may have HIV or is immunosuppressed. And there are a wide range of microorganisms which may cause neurotropic change. For example, CMV, VZV, HSV, the JC virus, Cryptococcus, Toxoplasma, Staphylococcus aureus, Nocardia, Bacteroides, TB, Aspergillus and Candida, to name but a few. Obviously, if the patient does turn out to be immunocompromised and vulnerable to any of the aforementioned organisms, it's important to be aware of what their CD4 count is if this information is available. In those with a normal immune system, it's also worth considering tertiary syphilis, which is on the increase within the Western world, as well as septic emboli and endocarditis, or in the very elderly patient, listeria, or Lyme disease, if the patient is, for example, a keen hiker or camper. Trauma is less likely to be encountered within the MRCP, but could be considered as a potential differential. And we could mention, as previously, the spinal cord hemisection, if there were a neuromesis or neopraxia over the course of surgery, if the patient had a fall and developed a traumatic intercerebral hemorrhage or concussion, or if they develop features of syringomyelia in a post-traumatic case. There are a wide variety of autoimmune diseases which can cause neurological changes, which include the vasculitides. Mononeuritis multiplex is often a consequence of the vasculitides. However, they may not quite present in this fashion, and they may directly involve the central nervous system as well. This would be less likely in a large vessel vasculitis, but the medium and small vessel vasculitides would carry a possibility of cerebral involvement. SLE is another common cause, and the myasthenias could show some weakness and may be mistaken for myasthenia gravis or other neurological conditions. Other causes may be the inflammatory arthritides, Guillain-Barré syndrome and its associated syndromes such as Miller-Fisher, limbic encephalitis as mentioned before, so looking for the anti-voltage gated potassium channel or anti-NMDA receptor antibodies, or multifocal motor neuropathy. There are a wide range of metabolic diseases as well, such as thyroid disease, diabetes and its whole range of neurological consequences, lysosomal storage disorders, acute porphyrias, Wilson's disease, hemochromatosis, alcohol excess, and leading on from this, acute or decompensated liver failure, or hyperammonemia from another cause. And we need to make sure the patient's not on valproate in this case. Could they have a nutritional deficiency, especially vitamins B1, B3, B6, B12, folate or vitamin E? If they've got CKD, could they have a uremic neuropathy? And are they a canned tuna enthusiast who's developed some heavy metal poisoning? Next we move on to iatrogenic. And this is not uncommon, it's things that we tend to do that often cause damage, and neurological disease is no exception. So as we mentioned, post-surgical or post-interventional complications, for example, recurrent laryngeal nerve damage in a transbronchial biopsy. Have we rapidly corrected electrolytes leading to progressive multifocal leukoencephalopathy? Have they had a prolonged intensive care admission and developed a critical care myopathy? And again, their drug history is extremely important. Could they have a neuroleptic malignant syndrome, a serotonin syndrome, or be taking a drug with direct neurotoxicity? Neoplastic causes are another common cause you may encounter. When thinking about central nervous system tumours, we have metastatics. Less commonly, but still relevant, are the primary brain tumours, such as glioblastoma, CNS lymphoma, ependyoma or meningioma, pituitary tumours, craniopharyngiomas, paraneoplastic cerebellar syndromes, which are important not to forget, and don't forget your anti-neuronal antibodies, as well as carcinoid syndrome. And finally, congenital causes. I think it's somewhat unlikely, but it's worth having Arnold-Chiari malformations in the back of your mind, as well as much more likely genetic conditions such as Charcot-Marie-Tooth disease or the muscular dystrophies or mitochondrial myopathies. Do they have any trauma at birth, giving them a cerebral palsy? Or do they have a primary epilepsy? Moving on now to the drug history. Prescribed drugs are only part of the history. Increasingly popular are Ayurvedic preparations, and these contain significant quantities of heavy metals, particularly lead, mercury and arsenic, and a thorough screen of all complementary medicines is essential. Alcohol, as a common drug of abuse, is both a central and peripheral neurotoxin, and other recreational drugs may have neurological side effects acutely, such as caffeine overdose, MDMA use leading to subsequent water intoxication, or more chronically, such as when there are septic emboli in injecting drug users. Be particularly wary of subacute combined degeneration of the cord in those who regularly use nitrous oxide. This includes both recreational use and infrequent attenders to A&E who misuse ambulance Entonox supplies. These people are particularly vulnerable to rapid depletion of vitamin B12 and potentially irreversible consequences. It should be noted that the nitric oxide used within the hospital setting, for example, with inhaled nitric oxide therapy on intensive care, does not cause B12 depletion. We move on now to key groups of prescribed drugs which may lead to neuropathies. These include chemotherapy, particularly vinca alkaloids, taxols and platins, immunotherapy, antibiotics, such as metronidazole, nitrofurantoin, dapsone, fluoroquinolones, ethambutol and isoniazid. Immunomodulators are another key group, such as tacrolimus, gold, leflunomide, thalidomide and its derivatives, such as lenalidomide, or MMF. And then there are some other miscellaneous drugs which are important to remember, such as disulfiram, amiodarone, colchicine, and antimalarials. The social history is extremely important in neurological disease. It's important to ask about the patient's job. Could they have had exposure to toxic agents such as in paints or dyes? Or do they work with lead in the roofs of old buildings? Is the patient going to be able to continue work at present, and how can you support them to do so? Is their condition going to prevent them from driving, and if so, will they lose their job? This is often a key part of exploring the patient concerns and a key safety feature in examination settings as well as in real life. Lumped in with this should be the family history. Affected relatives are particularly relevant in assessing for genetic causes, and you don't really need me to tell you that. But it may help you narrow things down between dominant, recessive and X-linked causes. Ethnic origin, as a rough rule of thumb, can help you raise your pretest probability of certain disorders. For example, looking at Gaucher's disease in the Ashkenazi Jewish population. The age of onset is useful, as a progressively earlier onset may reflect the phenomenon of anticipation in a trinucleotide repeat disorder. Make sure to also inquire about other illnesses running in the family, such as berry aneurysms or diabetes, as this may also help your diagnosis. If the patient is adolescent or at university, it's important to ask about their academic performance, as this can provide broader context to a neurological disease. Travel history may raise suspicion of potentially infective causes. We'd look at tick endemic areas, considering Lyme disease worldwide, tick paralysis if in North America or Europe, Japanese encephalitis in Asia, mosquito-borne disease, for example, cerebral malaria or African trypanosomiasis, or parasitic infection if the patient had an eosinophilic meningitis, particularly occurring within Asia. Mammal-derived disease is also relevant, so we'd think about dog bites, for example, or bat bites leading to rabies. Consider respiratory transmission, as in leprosy, or the fecal-oral route, such as shellfish or Singuera paralysis, onset typically occurring 30 minutes after the meal, typhoid or enteroviruses, which include polio. It's also helpful to interpret clinical tests. If you're considering syphilis and you have a positive test, could the patient have previously been exposed to yours, if, for example, they're raised in the Caribbean? Lengthy periods in leprosy-affected areas may also help to bring this into focus if there are other consistent features. As part of this social history, it's important to also look at sexual history or behaviours to help you guide diagnosis and look at the risk of conditions such as HIV or syphilis.